Hi everyone. First, I'd like to congratulate the board for this great success of this annual meeting. It's really a pleasure to be with you all. Today, within the next few minutes, we will touch on the issue of hypertension, and we will give some spotlights on Nebivolol, which is sometimes called the non-traditional beta blocker. First, this is my disclosure. I'm thankful for Sanofi for inviting me. And in order to get engaged, let's start by a clinical case, which is actually a daily case we met in clinical practice. She is a woman, Mrs. M.A., which is 50 years old, coming to the outpatient clinic complaining of shortness of breath. She is known to be hypertensive for 11 years, and she gave a history of dyslipidemia for 10 years. Her blood pressure is 145/100, and her heart rate is 94 beats per minute at rest. She is currently, as we can see, taking lisinopril 10 milligrams per day for hypertension and rosuvastatin 10 milligrams per day for cholesterol. Her investigations came as follows. Her creatinine was 1.1. The LAT was normal, the AST was normal, the total cholesterol was 132, and the LDL was 70. Her ECG was normal. Her echo came with an ejection fraction of 52% with normal dimensions, without systolic regional wall motion abnormalities. The interventricular septum and the posterior wall thickness was normal, but with a diastolic dysfunction grade 1. Actually, this is a routine, nearly daily case we met in our clinical practice. Please, friends, remember, when we are treating hypertension, actually we are not dealing with absolute numbers. We are treating patients with numbers. So, any physician's objective is to reduce the future cardiovascular risk in this patient through treatment of hypertension. And this is my first question. What do you think the cardiovascular risk of this patient is? Is it low or high or very high? This is how the risk, future risk, is calculated. Frankly speaking, it's an interplay between two main factors. The first is the number of the blood pressure itself, and the second is the presence of comorbidities and risk factors. Our patient is in grade 2 hypertension according to the European definition. Her diastolic blood pressure is 100 millimeter mercury, and she is having dyslipidemia. So its future risk for cardiovascular disease development or cardiovascular related mortality is at least moderate to high. Really, the cardiovascular disease will remain the leading cause of mortality worldwide for some time, according to the data coming from the WHO. And if we are exploring the deaths attributable to the most common 19 risk factors by country level, we will find that hypertension is ranking number 1. No difference here between high income, middle income countries such as Egypt, and low income countries. And unfortunately, according to the data published by Professor Mohsen Ibrahim, and I am privileged to see him sitting in front of the audience, and his group back in the 2013 in the Egyptian Heart Journal, it was estimated that more than 26% of the Egyptian population, and I'll say it again, more than 26% of the Egyptian populations are having hypertension. And unfortunately, the control rates at that time were poor. 8% of those patients reached to the goal, which was at that time 140/90. Can you imagine these figures? Egypt in 2021 is not better. According to the data in the Cardiorisk project we published recently in February 2021 in the Journal of Public Health in Africa, and this was a huge nationwide cross-sectional study comprising more than 3,200 patients from 2015 to 2019. All patients were having ACS, more than 30 coronary cardiologists distributed alongside Egypt. We found that hypertension is ranking number 2 among the most common risk factors in Egyptian ACS population after abdominal obesity. Sit down for this, the prevalence of hypertension was exceeding 50% in male subjects and 70% in female subjects. In other words, this means that 1 in every 2 Egyptian ACS patients, male patients, are having hypertension, and 3 of every 4 women Egyptian patients with ACS are hypertensive. And as a medical writer for Cardiovascular News and in a telephone contact with Professor Salim Youssef, the renowned international epidemiologist and the PI of many multinational international studies, such as the HOPE series of trials and recently the PolyPel study for prevention of cardiovascular disease, he said, quote, "It's useful as a starting point for Egypt. However, it's hardly surprising. The numbers were very high to him. And he said, quote, you have to act." This is my second question. What's the goal blood pressure in this patient? Should we suffice with 140 over 90 or 140 over 80, or should we go below 130 over 80? If we saw what have been changed from 2013 to the last version of the European guidelines in 2018, we will read that in 2013, the guidelines were recommended a systolic blood pressure to be less than 140 millimeter mercury, full stop. However, in 2018, the guidelines are still recommending to reach at least to 140 over 90 in all patients, but this is provided that the treatment is well tolerated and those targets should go below 130 over 80 or lower in most patients. And in patients who are less than 65 years old, the guidelines recommended a systolic blood pressure target in the range of 120 to 129. The same was for diastolic blood pressure targets. In 2013, the diastolic blood pressure target was less than 90 in most patients except in diabetic patients whose targets were slated to below 85 millimeter mercury. But in 2018, we have a class 2B recommendations that a diastolic blood pressure target should go below 80 in most patients independent of the level of the risk and comorbidities. And this table from the recent guidelines speaks it all. If you look to the table carefully, you will find that the diastolic blood pressure target is in the range of 80 to 70 in most patients, whatever the age, whatever the comorbidities. However, if we look to the systolic blood pressure targets, we will find that it was according to the age. For example, from the age of 18 to 65, the systolic blood pressure target is targeted to 130, but not below 120 if tolerated. Look at this, if tolerated, except in patients who are with chronic kidney disease, whose systolic blood pressure target are permitted to be a little bit higher in the range of 140 to 130. Other age groups, from 65 to 80 and more than 80, the systolic blood pressure target is 140 to 130 in this range, again, if tolerated. And recently, the 2020 International Society of Hypertension guidance went to the same targets. If you look closely, in patients who are less than 65 years old, their blood pressure target is less than 130 over 80 if tolerated. And in elderly, more than 65 years old, the blood pressure target is a little bit higher to less than 140 over 90 if tolerated. Remember this, if tolerated. But what about heart rate? Are we forgetting something? Yes. Actually, frankly speaking, no one in this hall knows why hypertension develops. There are many theories. We have the theory of the enhanced activity of the sympathetic nervous system, the theory of augmented renin-angiotensin system activity, and the theory of increased total body sodium content. All these three factors are in play in each patient with different proportions. And if we went back to the basic physiology and say the three pillars of blood pressure, you can think about this equation. The blood pressure equals cardiac output multiplied by systemic vascular resistance. Cardiac output itself is equal to heart rate multiplied by stroke volume. The stroke volume is greatly dependent on the contractility. When you have higher contractility, you have a higher stroke volume. So from this simple equations, you could extrapolate the data of the three pillars of the blood pressure in humans, which are the systemic vascular resistance, the heart rate, and the contractility. And we know also from the basic physiology that the sympathetic nervous system has a direct influential effect on these three pillars: the heart rate, the systemic vascular resistance, and also the cardiac contractility. Moreover, it goes without saying that the sympathetic nervous system activity has a close relation to the rest system activation. If you remember the juxtaglomerular apparatus of the kidney, you have there what we call the beta-1 receptor secreting renin. And in patients with increased sympathetic activity, there is increased renin, which leads to the downstream consequence of the increased secretion of angiotensin II, and finally, the aldosterone, increased systemic vascular resistance, increased total body sodium, and potential development of hypertension. And we have data. The data are there. Look with me to this important study published in the Journal of the American Society of Hypertension, in which investigators found a graded increase in the sympathetic nervous system tone measured in the clinical research, but what we call the muscle sympathetic nerve activity, or MESNA. If you went from the normotension, passing from pre-hypertension to borderline to moderate and then resistant, as you can see, you will have a significant graded increased level of the muscle sympathetic nerve activity. And if we focus on middle-aged subjects who are usually characterized by enhanced activity of the sympathetic nervous system, in this important paper, you will find also the same results: a graded increased sympathetic nervous activity when you are going from the normal levels of the blood pressure up and up to the severe grades of hypertension. So, it's not surprising to speak about the heart rate as a risk factor, not a risk marker. And we have robust data. Do you remember the Framingham study? According to this sub-analysis comprising more than 5,000 patients with nearly 30 years of follow-up among both sexes in all ages, all-cause mortality increased significantly and progressively with increasing the heart rate, taking resting heart rate as a continuous variable. Another important subgroup analysis published in the New England, comprising more than 5,700 patients with more than 20 years of follow-up, found a great significant association between resting heart rate, and the future risk of sudden and non-sudden cardiac death. For example, if you compare those patients who had heart rate below than 60 to those patients who had heart rate more than 75, you will find nearly a 5-fold increase in the incidence of sudden cardiac death. Another important sub-analysis focusing on the group I am speaking about, the middle-aged subjects from the same data set, the huge Framingham study, more than 2,000 patients, more than 35 years of follow-up, a significant relationship were found between heart rate, all-cause mortality, mortality due to cardiovascular disease, and mortality due to coronary artery disease per se. So it was not surprising when you are looking to the 2018 European guidelines for management of hypertension that it included heart rate, specifically speaking, resting heart rate more than 80 beats per minute among the factors influencing the future cardiovascular risk in patients with hypertension. And this was new. And these same guidelines gave class 1 recommendations that all patients with coming to clinical examination in general should undergo pulse palpation in order to detect arrhythmias such as tachycardia, specifically speaking about atrial fibrillation. And I'd like to grasp your attention to our population pyramid that was slated in 2020. If you look closely to the pyramid, you will find that the vast majority of the Egyptian populations are belonging to the middle-age group, from 30 years up to 60 years old. This age group, not only, as I just mentioned, are characterized by enhanced activity of the sympathetic nervous system, but the pathophysiology of hypertension in this group is completely different when you compare it to the pathophysiology of hypertension in the elderly. I will summarize this table into two main points. One, the density and sensitivity of beta receptors in the middle-aged younger group is significantly higher compared to the older population. So, you will find that the pattern of the hypertension in this age group is characterized by what we call a low pulse pressure, compared to the elderly, in which we have the entity of sometimes isolated systolic hypertension. And this speaks about the utility of beta blockers in this age group, and also at the same time speaks about the importance to act on the arterial compliance in the elderly, and this explains why calcium channel blockers are having a good reputation in this group. And back to our patients, who is a middle-aged female hypertensive, it is logic to speak about the role of beta blocker in this patient. And if we went back in the history and see the evolution of beta blockers, back in 1960, we had those non-selective beta blockers which blocked both beta-1 and beta-2 receptors. The prototypes of this group was propranolol. And then 10 years later, we had those selective beta blockers, and this was a huge achievement, which blocked selectively the beta-1 receptors, and the prototypes of this group were atenolol and metoprolol. Later, back in 1990s, we had the third generation beta blockers who had peculiar vasodilating activity through alpha blockade, and the prototype for this group were carvedilol and labetalol. And then in 2007, we had another selective vasodilating beta blockers belonging to the third generations, which produces vasodilation through the release of nitric oxide, and the prototype of this newer group was nebivolol. The most important two characteristics that differentiate nebivolol from other beta blockers in general, and specifically the vasodilating beta blockers, are one, its high grade of selectivity. For example, its selectivity on the beta-1 receptors is more than 300 times greater than propranolol, and 3 times or more greater than bisoprolol, which is in and of itself cardioselective beta blocker. This is in addition to its action through which it produces vasodilation. It acts on the endothelial nitric oxide, or eNOS, and leads to a significant increase in the production of nitric oxide. And we know that nitric oxide, which is otherwise known as endothelial-derived relaxing factor, has a potent vasodilatory properties. But beta blockers are not homogeneous group. They differ among each other in 4 main criteria. Number 1, as I have said, the beta-1 selectivity. Number 2, as I just heard a few minutes ago, the IMA, or intrinsic sympathomimetic activity. Those beta blockers without intrinsic sympathomimetic activity are more effective. Number 3, the lipid solubility. Number 4, as I just mentioned, the vasodilatory properties. And if we put nebivolol, to be fair, in a comparison with other beta blockers in the context of hypertension, again, we will say it's nearly the most selective beta-1 beta blocker. It doesn't have an alpha blockade activity. It has a mild lipophilic activity, and importantly, it has no ISA or intrinsic sympathomimetic activity, and this could translate into a higher potency and efficacy. Finally, again, it produces vasodilation through the release of nitric oxide. And if we are going to extrapolate these characteristics into the theoretical potential clinical advantages of nebivolol, we will say the following. Number 1, it nearly has no effect on the airways, so it could be suitable in those patients with COPD, particularly those patients who have a great element of bronchospasm. Not all patients with COPD are contraindicated to use beta blockers. However, those patients with bronchospasm may be suitable to receive nebivolol in smaller doses. It nearly has no effect on glucose metabolism and the lipid metabolism, so nebivolol could be suitable for those patients with cardiometabolic disorders such as diabetes and dyslipidemia, and this is actually the case in our patient. Moreover, the nitric oxide is known for its potential platelet inhibitory effect. So theoretically, the use of nebivolol may be favorable in the balance in the thrombogenic fibrinolytic system. Finally, it could be suitable for those patients with erectile dysfunction. I confess that the erectile dysfunction issue with beta blockers is vague and is related to what we call the nocebo effect, but we will show now data that patients transitioned from other beta blockers to nebivolol showed some degree of improvement in the erectile dysfunction scores. All of this is nice, but we need data. All of these are theoretical speaking. We need clinical data proving at least these potential clinical issues. Number one, look with me to this paper that was published in the British Journal of Clinical Pharmacology, in which nebivolol, but not atenolol, caused significant vasodilation and improvement in the forearm blood flow, both in healthy male subjects and in those with essential hypertension. Another important randomized study published in the journal Hypertension of the American Heart Association, comparing nebivolol to metoprolol in terms of improvement of the insulin sensitivity, endothelial dysfunction, and the parameters of the thrombogenic system. If you look closely, you will find that plasminogen activator inhibitor 1, PAI1, which is known physiologically as a bad molecule, showed a significant increase in metoprolol compared to the situation in which nebivolol caused significant reduction in this bad molecule. Another important study whose results were announced in the annual scientific sessions of the American College of Cardiology in 2018. This was a huge observational data set comprising more than 50,000 American patients, in which nebivolol investigators showed that nebivolol was associated with a lower risk of cardiovascular related hospitalization compared to those patients receiving atenolol and metoprolol. All patients were American patients receiving combination therapy for hypertension. And not only this, take that. In an important trial comparing nebivolol to bisoprolol, both molecules showed similar efficacy in terms of diastolic blood pressure reduction. However, nebivolol showed significantly lesser incidence of adverse reactions, and this is thankful to its cardioselectivity in addition to nitric oxide release, which could translate into improvement of endothelial function. This was called the NEBIS study. And to debunk the claim that all beta blockers cause erectile dysfunction, please look with me to this important data, follow-up of more than 2,800 men for more than 5 years, in which, as you can see, the selective beta blocker group, the age-adjusted relative risk for self-reported erectile dysfunction was 1, which means statistically a neutral effect. Compare it to the group of non-selective beta blockers, for example, and even surprisingly, angiotensin II antagonist, in which the age-adjusted relative risk was exceeding 2, double the risk. Another important study, albeit small study, but a very important one, it was published in the Asian Journal of Andrology, in which investigators found that those patients transitioned from other beta blockers to nebivolol showed more than 65% significant increase in the erectile dysfunction scores. Now, I'd like, before I finish, to correct some 2 fake news into 2 correct facts. Number 1, it's sometimes said that beta blockers cause strokes. No, this is wrong wording. The correct wording may be the following. Beta blockers might be less protective in terms of future reduction of strokes compared to other classes of hypertension. But stop here and think. The data are provided from those older studies done on the old atenolol. However, if we combined all the recent data with the recent beta blockers, for example, in this important meta-analysis that was published in the Journal of Hypertension and was co-authored by the famous Italian professor Giuseppe Mancia. This was a meta-analysis of more than 65 blood pressure lowering trials comprising more than 68 patients. Look to the stroke effect and the relation to beta blockers. No difference. No difference between what and what. No difference between beta blockers and control. And the control group in this meta-analysis was those patients without hypertension, without treatment of hypertension, with lesser intensive hypertensive therapy, or those patients receiving antihypertensive therapies other than beta blockers. And this is important. And this might be due to the differential impact of different beta blockers on the central aortic blood pressure. And we have data. Look with me to this important data published in the journal Hypertension, in which nebivolol caused a significant reduction in both central, systolic, and diastolic blood pressure compared to metoprolol in a follow-up exceeding 50 weeks. And this is important. Another claim that I'd like to correct is that it's sometimes used that beta blockers have been knocked out from the recent guidelines. There is no place in the recent guidelines for beta blockers, and this is wrong. The correct wording is that beta blockers have underwent some better and better employment into their true indications in the recent guidelines, those that we call the compelling indication. And if you simply search the recent guidelines, look to the 2018 European guidelines, you will read the following. Read with me. Among all hypertensive drugs, ACE inhibitors, ARBs, beta blockers, calcium channels, diuretics, have demonstrated effective reduction of the blood pressure and cardiovascular events in RCTs, and thus should be the basis of antihypertensive treatment strategies. Searching the table more and more, look to table 15, to the drugs to be preferred in certain conditions. You will find that beta blockers in general, and of course nebivolol, are preferred in those patients with previous myocardial infarction, hypertensive patients with angina pectoris, hypertensive patients with heart failure, hypertensive patients with aortic diseases, atrial fibrillation, both for prevention and rate control, and of course hypertensive patients with pregnancy. Now, I'd like to quote you two sentences, one from the recent European guidelines and one from the recent American guidelines. If you look first to the first sentence, read with me. Beta blockers are not homogeneous class. In recent years, the use of vasodilating beta blockers, nebivolol, for example, has increased. Studies on nebivolol have shown that it had more favorable effect on central aortic blood pressure, and we have said that, aortic stiffness, endothelial dysfunction. It has no adverse effect on the risk of new onset diabetes, and more favorable side effect profile than classical beta blockers, including less adverse effects on sexual dysfunction, and we have said this. But I scientifically have to confess that unfortunately, we have no RCT level of evidence demonstrating reduction in outcomes with these newer beta blockers in hypertensive patients. The same was for the 2017 American guidelines, which stated that newer vasodilating beta blockers, specifically mentioning nebivolol, have shown neutral or more favorable effects on metabolic profiles. Again, trials using these vasodilating beta blockers have not been performed to demonstrate effects on the cardiovascular disease outcomes. My final take-home messages are the following. Number one, the role of sympathetic nervous system and heart rate in the development and progression of hypertension is well established. Number two, most of the benefits of different antihypertensive medications comes from the mere reduction of the blood pressure. In other words, what reduces wins. In the absence or in the presence of hypertension with compelling indications such as tachycardia, ischemic heart disease, there is no difference in the guidelines regarding the role of beta blockers. Complete agreement. However, I confess that the position of beta blockers in treatment of hypertension without a compelling indication is a matter of debate. It needs a further research. Finally, beta blockers with vasodilatory effects are clearly welcomed in the guidelines of treatment of hypertension. I'm grateful that you listened. Thank you. This was me.
شكرا دكتور
Thank you.
احمد.
Thank you.
شكرا جدا. Any questions from the floor?
Thank you, Dr. Ahmed, for your presentation. I'm Mohammed El Basit, lecturer of cardiology, Zagzag University. The success of nebivolol should raise a concern to us in sympathetic overactivity. There is increase in blood pressure and increase in heart rate. Why the research is focusing on use of only beta blockers without alpha blockers? Is there any data of combined beta blockers and alpha blocker in sympathetic overactivity or not?
Yes. Actually, the third generation beta blockers, such as labetalol and carvedilol, are producing both beta blockade and alpha blockade activity. And they are among the vasodilating beta blockers that are recommended for treatment of hypertension, especially those with compelling indication. The data are there for carvedilol and labetalol, but the data were not extensive, maybe for funding reasons. No company has funded a major multinational randomized controlled trials in this molecule group in general, whether speaking about nebivolol, labetalol, carvedilol, to demonstrate reduction in the major hard outcomes in hypertensive patients. maybe due to funding reasons and so on. Those trials needs millions of dollars.
Any questions? شكرا دكتور أحمد.
Thank you very much. It was a pleasure.